We have Dr. Shetty to talk on decision making in strabismus surgery, a systematic approach. Over to you, sir.
Good afternoon, everyone. I like at the outset I like to thank Dr. Vijayama for calling me for this great instruction course. I'll be talking on decision. I think most of the speakers have covered all the different type of strabismus. So I'll be just talking on decision making in different type of strabismus. So when we do strabismus surgery, what is our goal? Our goal is to eliminate the relative deviation of the eyes, like compared to both eyes. If the eye is ESO or EXO, so our goal is to reduce the strabismus. So why you want to reduce the strabismus? Why you want to do surgery for the patient's strabismus? So the main goal is to get binocular vision for the patient and to get a 3D vision. And if they have diplopia, we need to eliminate the double vision. And personality and cosmesis also plays a good role. And even if the patient's stereo vision or binocular vision doesn't improve, studies have noted that there's improvement in their binocular fields. Patient can see better now, even if there's no response in their binocular vision. Like they are still suppressing, but they have noted improvement in their binocular fields. So in a child, when you operate, you might, the parents may say the milestones have become better. Child is able to walk better, no? Reach to objects better. So I'll be talking on esotropia, infantile esotropia, partial accommodative esotropia, late onset and paralytic esotropia. So infant is esotropia. What is the age? So patients might ask you, when is the best time to operate this child? As one of the speakers has told that inferior oblique overaction may develop over a period of time after the age of 1 year. So we prefer to operate them by age of 1 year if you are able to measure the deviation. Even dissociated vertical deviation can develop later on after you operate the infantile esotropia. If you read the Adler's physiology of the eye, which states that the binocular vision, the simultaneous perception, fusion, and stereo develop within 1 year of age. Okay, so if you operate them early, the chance of developing binocular vision is better. But there is always a risk of not measuring the deviation properly, and later on child developing dissociated vertical deviations. So when you operate, you tell the parents that child might require one more surgery after your initial surgical correction. So the max medial rectus recession, what we do is 7 millimeters for an angle of 60 prism diopters. So we start with maybe 3.5 millimeters medial rectus recession to 7 millimeters is a max, because there's a possibility, if you do more than that, there's a possibility of patient developing consecutive exotropia. So these patients they might have associated infantile nystagmus syndrome, okay, or they may have something called as fusion maldevelopment nystagmus syndrome. I think people will feel sleepy seeing those terminologies. So there is nothing called a latent nystagmus. So patient can have fusion maldevelopment nystagmus, because why it is important is patient may have head posture. If they have a FMNS, they might keep a head posture to keep an adduction null. So they might do like this, and they might bring that eye with a better eye in the adducted position and block the nystagmus. Okay, so when you operate those patients, you will reduce their face turn as well as the esotropia. But if they may have head tilt, so then you have to think of, they might have an idiopathic infantile nystagmus, or they may have a coexisting DVD. So if you correct their esotropia, the head tilt might persist because we are not treating their INS, or the INS might get better, or you are not treating the dissociated vertical deviation, which will create a head tilt. The head tilt is always towards the side of the fixing eye. Okay, it can be a contralateral head tilt also, but most of the time it's an ipsilateral head tilt towards the dominant eye. That is because of your, when they tilt, they are stimulating their inner ear, the endolymph is stimulated, and that causes stimulation of the vestibular cells, and that stimulates the medial vestibular nerve. And children who have delayed milestones, so those patients, there's always a possibility of those developing, they can develop spontaneous exotropia. From esotropia, they then become exotropic. So in those patients, we can do little less surgical numbers. And we need to add inferior oblique, as the previous slide showed, patients having inferior oblique overaction which can coexist with esotropia. So you need to add inferior oblique surgery. So what we do is we do a inferior oblique antro positioning, little bit anterization of the inferior oblique to prevent future DVD from occurring. So that will correct a V pattern as well as the future recurrence of DVD. And as the previous speaker has told about the accommodative esotropia, which can be corrected with glasses. So initially this type of esotropia will usually present by 18 months, because where the child is trying to read, trying to accommodate, and then you will find this patient developing esotropia. So in those patients, we need to treat them initially with glasses, and if there is a non-refractive component with high AC by ratio, then we need to give them bifocals. So first is give the full correction. If the esotropia is persisting for near with a high AC by ratio, then you need to give them bifocal glasses. So as you either give them executive bifocal or D-shaped bifocals with the upper margin of the bifocal bisecting the pupil. And if the esotropia is very significant, AC by ratio is low, so and they are not responding to bifocals, then we need to do a surgical correction for the esotropia. So why we want to operate this esotropia is to get the esotropia towards a very small angle, like to microtropia, very small angle deviation, so the patient develops binocular vision. The whole idea of operating this patient, giving glasses, so that the patient develops binocular vision. We have seen a lot of cases of late onset esotropia recently, which are basically either could be a decompensated esophoria. So they might have a latent deviation and decompensated to esotropia, and it's also common in patients moderate myopes. Prolonged device usage can also cause late onset esotropia. We image all these patients to rule out intracranial cause, and then we need to do an early surgery to prevent suppression. And intermittent exotropia, when we need to operate, that's a very big question. So we avoid surgery if the child is less than 4 years, the possibility of developing consecutive esotropia. And if they have very good control, excellent control, so we don't touch them. We either give them minus lens therapy with small prisms, basin prisms, that helps them to accommodate and then converge and reduce their exodeviation. Or you can also try orthoptic treatment like alternating eye patching. And patients where we need to operate, we do patch test for all patients with exotropia. We do a gradient method AC by ratio for distance. I know it's little on the higher side. And we do a ultra near testing for exotropia. Ultra near testing is we keep the target close to your eyes at 10 centimeters, and then we look for, we do a cover test and look for esophoria. Okay, if they are esophoric and if they have a high AC by ratio for distance, then it is called as true divergence exotropia. And those patients, we have to be very careful when you operate, because they can develop consecutive esotropia. So in those patients, we can give them minus lens therapy as bifocals. You give a bifocal like a high minus at the top, and you give less minus in the down. So that takes care of the exo for distance. And if the deviation is, we call it a pseudo divergence, pseudo AC by ratio, where AC by ratio is more for near, but the gradient method for distance is on the lower side, and they are exophoric for ultra near testing, then we operate those patients. So we can have convergence insufficiency, where we can do a patch test to differentiate between true convergence insufficiency and pseudo convergence insufficiency. So again, true convergency, there are two types, is accommodation and fusional insufficiency. So we treat them by either by glasses or by a slanted recession resection. And large angle exotropia, if there is more than 50 prism diopters of exotropia, we do 3 muscles. And if it's like 60, 70, we do 4 muscles. And if the patient has got an amblyopia eye with large angle exotropia, we do a muscle transplantation. Fourth nerve palsy, in congenital patients, we operate them early because they will have head tilt and they can also develop facial asymmetry and degenerative osteoarthritis if we don't treat them early because of the constant head tilt. And if it's acquired palsy, and then we look at their torsion, we look at the side gaze deviations, and we measure their deviation in the primary position, and we do surgery. We can do like superior oblique tuck or multiple procedures to reduce the torsion. See, patients in fourth nerve palsy, especially post-trauma, patients presenting with torsional diplopia, they will not complain of torsion, but they will complain of blurred vision and blurred down vision. They say when you check their vision, they will be N6, but the patient will say they will have little blur. So you need to look at their torsion. So inferior field defects and bilateral uncorrected torsions can cause defective near vision and a constant blur. So you need to do a double Maddox rod and check their torsion. And for if you see a child with nystagmus, when we need to intervene surgically, if there is a large head posture, we need to look at the stabilization of the face turn. We wait till the age of 6 years. We try orthoptic management, medical management to reduce their face turn, and then you have different surgical armamentarium to reduce their face turn. We also do eye movement recordings. We do eye movement recordings in patients with nystagmus to look at pan, periodic alternating nystagmus, look at their multiple null points, and there is something called as nystagmus acuity function. So when we correct nystagmus by treatment, we are not just correcting the face turn of the patient. We are actually correcting the different gazes vision of the child, because the child is going to look at different gazes when they can have nystagmus. So that is called as gaze dependent visual acuity. Gaze dependent visual acuity. And there is something called as fovation time, fovation period, which improves when we correct their nystagmus. And in patients with third nerve palsy with aberrant innervations, so in those patients we don't operate their affected eye, we operate their non-affected eye. When we operate the non-affected eye, we create a fixation duress, so we reduce their deviation in the primary position as well as improve their ptosis. So when the patients with, as you can see in this photograph, in that primary position there is a ptosis, and when the patient looks in levo version towards the left gaze, you can see the ptosis getting better. This is inverse Duane sign. So those patients who have this inverse Duane sign, we don't operate the eye with the third nerve palsy, we operate the other eye. As madam is told about the double elevator palsy, when we see a patient with double elevator palsy, look at their chin elevation. Always look for binocularity in the down gaze. That is very important. If the patient is binocular, then you don't need to touch their inferior rectus, because then you're going to create double vision in the down gaze. And look for dissociated torsional deviation in patients with double elevator palsy, because many of these patients can have coexisting DVD, and if you operate this patient, then there's a possibility of them developing consecutive hyperdeviation. If the angle is 30 PD with a negative FDT, then we do a modified NAPS. And when you are doing an inferior rectus surgery in any patient, you have to be very careful, because a late slippage can occur, because inferior rectus has got a very short arc of contact, and the inferior rectus has a adipose tissue which is behind it, and it prevents the inferior rectus from getting attached to the globe. And there's a constant Bell's phenomena which prevents the inferior rectus from getting attached to the globe, causing an inferior rectus slippage. So that is a very important gaze, and the patient's got binocularity in the down gaze, and you're going to do inferior rectus surgery, then you have to be very careful. Duane's retraction syndrome, as the previous speaker has told. And this is a patient who had Duane's, already undergone surgery, had a residual esotropia. So we did a modified Nishida's procedure where you do no split, no tenotomy procedure, and it corrected the deviation very well in the primary position. And this is a patient with bilateral 6-nerve palsy where we did bilateral medial rectus recession with Nishida's procedure. So points to ponder. So when you see a patient with strabismus, always do an indirect. To rule out, look for retinal holes, because patient might say that after your surgery the retinal hole has developed. So look for retinal holes, do a careful indirect, look for retinal holes. At the same time, look for torsion in the fundus. So that will give you a lot of clue whether there's a coexisting oblique dysfunction. Look for conjunctival scarring. Sometimes patient may not give you a history that he was operated in the earlier age. So when you're doing a anterior segment examination, look very carefully for conjunctival scarring suggestive of old strabismus surgery, or they might have old retinal detachment surgery which can also induce strabismus. FAT scan. What is FAT scan? Can anyone tell? Excellent. Family album tomography, that will help us to tell what type of deviation patient had. Sometimes you can have a spontaneous consecutive exotropia. Patient might be isotropic. You look at his old photographs, he might be isotropic. And patient, you ask him what happened. He said, no, I have not undergone any surgery. Anterior segment is fine. So they can develop something called a spontaneous consecutive exotropia. From ESO, they might become EXO. Look for bleeding disorders. Ask history of bleeding disorders. Patient might have had history of previous bleed, which we might think may not be important. Patient can bleed during surgeries. So look for bleeding disorders. Check for fusion. Check for fusion. If look whether the patient is able to fuse. If the patient is not fusing, then he might be a risky patient. Then you have to look for other findings, like look for anisometropia. Look for anisometropia, look for uncorrected torsion. And post-operatively, careful about anterior segment ischemia. Patients who are smokers, they are very prone for developing anterior segment ischemia. So to be very careful, carefully look for anterior segment findings. And your surgical numbers will depend on your experience, like how much you have done previously and what is the numbers you're getting. That will depend on your experience. Thank you.
Thank you very much, sir. It was loaded with information for us.